Yeah, we are live now.
You start, Richa.
Yes, good afternoon, everyone, and very warm welcome to our 13th session of Tuesday Tea Time with Dr. Kawita Bapat, ma'am. And again, with a new topic, with a new special guest. But before starting the session, I would like to welcome Dr. Jyoti Karande, ma'am. She's Secretary IOGS, and I would hand over the session to you, ma'am, to take it further.
Thank you, Richa. I welcome respected seniors and dear friends to this session of Learn Simply. Learn Simply is a platform where a very precise and crisp information is given by experts in their field who are doing pioneer work and extraordinary work in their field. And today, this is started by Dr. Kawita Bapat, ma'am. I feel privileged to introduce her. She was President of Indore Society, President of Breast Committee, Vice President West Zone Foxy, and she believes that let's grow together with lot of great ideas, fun and laughter. And Learn Simply is simply a reflection of this thinking and personality. I request Dr. Bapat madam to introduce Dr. Kuldeep Singh sir.
Thank you so much. Thank you so much. Thank you. Please put a CV of Dr. Kuldeep Singh Sarji. And the most important point is the Learn Simply is taking a tremendous popularity day by day. And most I have seen into the YouTube. And today we are having a lovely guest of ours. We cannot call him a guest. He's our own person. He's an exceptional individual and a very good friend of ours, and who has made a significant impact in the field of ultrasound education. And he truly deserves the praise and recognition for his dedication and achievements. Basically, I just love the commitment of teaching he's having. So many people learn from you this thing, as evidenced by many talks he has given, awards he has received, and the most important is a testament of his skills and a passion in this field. And additionally, his contribution to the field through their writing, sharing his techniques internationally also. So many places he has been and demonstrated his keenness in advancing ultrasound education and improving patient care and around the world. So the Dr. Kuldeep Singh ji is basically overall an outstanding teacher and a leader in the field of education. And thank you so much today that given the consent to have a dialogue with me, and your contributions are undoubtedly made the positive impact on the countless individuals. And today's subject is also very good and important. That's a sonoembryology, a specialized area of ultrasound. And it innovates the study of developing embryo and the fetus, basically. And several nonsense in this field is important. So over to you. I'll ask few questions, and people will like to, you will like to listen a crisp and the smart answers from you. And so though it's a complex subject, sir, but a specialized training and expertise is always needed for the madam. So before we start, so first number one is welcome, sir. So should we start with a few questions so that you can answer?
Perfect. I would just add on with the things. This Tuesday tea time, I've been following it up. Last time Dr. Tank was there, and I've been following it up with Dr. Suchitra Pandit also when we had a portion over there also when we were talking on eclampsia. So it's always good fun. And I love the idea of that you finish a thing in half an hour's time so that then we don't have lengthy talks on 1.5 to 2 hours, because we just need few take-home messages. So rather than spending that much time, it's always good. Thank you, Dr. Jyoti Karande, for joining in as well. That's really lovely of you. Over to you, Dr. Kawita.
Thank you so much. So we start, and I'm really happy to have you today, as usual, as normal. So just to tell and ask it should be to our audience should know that before a scan, what all should be one looking for? See, the ultrasound is a very, though it has been taught, it has been thoroughly we are discussing and everything, but still few things which is a take home also, take work also. So before a scan, what all should be looking for, sir?
Before we start a scan, what is very important is you should have a proper referral slip. You should be looking in for filling up your PCP NDT forms, because that is very important. We can talk about clinical, biochemical, family history, patient's history, but if we are going to falter in any of these, we are into trouble. So apart from that, before you start a scan, take a history. If somebody is just doing a scan, there'll be many of you just be doing a scan. If you're doing your own practice and practicing ultrasound, yes, you would be aware. But otherwise, definitely make that extra effort, looking in the notes, the referral slip, what's the previous history, what's the beta HCG like, and does the patient have any symptoms whatsoever?
Okay. So the most important point whenever the patient comes, it's our responsibility to look all the referral forms and the patient history and everything. So, sir, how do you say that how soon one can see the pregnancy? It's a very common question to the all the OBGYN, though it's a very undergraduate or the practicing OBGYN think about. But it's a very difficult for most of them when to refer the patient and get the sonography done. So how soon one can see a pregnancy in a sonography?
The problem is the patient comes to you with a urine test for pregnancy, or the moment the urine test is positive, it's expected that you would be seeing a pregnancy.
Correct.
That's not the case. It's always has to be correlated with the beta HCG, and we all have discriminatory zones around 1500 to 2000. So the moment the beta HCG value is above that, that is when you really need the whole thing that, okay, if I do not see a pregnancy, if the patient is not bleeding, it has to be, or it should be an ectopic unless and until proved otherwise. So be very careful. It's not that jumping onto an ectopic and let's do a laparoscopy or let's call in for termination.
Yeah.
That's why we've chosen this topic. Go step by step.
Correct, correct. So as early as possible. And what makes us sure that I am looking at an intrauterine pregnancy? That's another question. When we talk about as soon as we see a pregnancy, but what makes us sure to that I'm looking at an intrauterine pregnancy?
Absolutely correct. I'm going to take your permission to share the screen because it's
Yes,
an
sir.
ultrasound
Yes.
topic. So
Yeah.
we would be needing to show a few pictures and the videos.
Yes, sir. Yeah.
I hope the screen is moving and you can all
Yes,
hear
sir.
me.
Yes, sir.
Right. So the moment you're looking at an intrauterine pregnancy, you would be having a few indirect signs. The few indirect signs would be that you would be having an asymmetrical thickening of the endometrium. So it could be anterior or posterior when you're not looking at a pregnancy. Or what you could be looking at, if there is some confusion and you want to be very, very sure, just switch on your color for a very few seconds and looking for any comet sign, meaning a thin stream of blood going into one of the specific areas. Otherwise, the short sign, if you can see over here, this is what we call the intradecidual sign. That's the cavity over there, and you're looking at a gestational sac. It's not in the cavity, it's located asymmetric. This is in the anterior endometrium.
Correct.
Secondly, if you need to be looking at, that's going to be displacing the cavity, and the earlier one was an intradecidual sign. This is a double decidual sac sign, and you'll start looking at a yolk sac. The gestational sac can be seen as early as 4.5 weeks on a transvaginal, and this portion of yolk sac can be seen from 5.5 to 6 weeks onwards.
So yolk sac at 5.5 and 4, that is, yes, sir. Just as pregnancy, we can see at 4.5. Am I right, sir?
Absolutely,
Yeah,
absolutely.
yeah. So
There's some disturbance. There's some disturbance, Dr. Richa. If you could mute yourself, G.
yeah. So anything like that, that the which we are, any point which you really want to add over here regarding I'm looking at intrauterine pregnancy other than these two signs or anything else?
Well, the next sign that you're going to be looking at is the embryo with a cardiac activity, and then I posted in the Sono School groups as well. You could be looking at a double bleb sign with the embryo in between. So these are the factors that tell me I'm comfortable. Normal cardiac activity, which we're going to be discussing later. One knows we're looking at a normal pregnancy.
Amazing. So, sir, so what are some common techniques basically to assess the fetal heart rate in the ultrasound? And can you tell me about what is the good fetal health this is? Because at this time, patient wants to know sab theek hai, everything is okay. So being a simple, it's just a program for simply we are not talking something very high profile thing, but just a basic thing. What common techniques for assessing the fetal heart rate, sir?
The best technique and the most commonest technique is eyeballing. You can see the heart beating, show it to the patient. What you're not supposed to be doing is never use color or Doppler to make the patient hear the heartbeat, especially in early pregnancy, because
Yes.
that's something very common mistake that we all do, and that's really not good. The other thing which we can do and figure out is by the M mode, which is going to
Yeah.
tell us about the heartbeat. So you can see
Okay.
all these waves over here, and depending on what you've chosen, you can choose from 1 or 2 heartbeats and figure it out.
Okay.
From 6 to 8 weeks per the weeks, it's going to be 100 to 130 beats per minute is regarded as normal. The moment it's more than 8 weeks, a heartbeat should be more than 130 beats per minute. Less than that, you're going to be terming it as bradycardia. And how we're going to be using all that is going to be coming up in a few slides.
Correct. So this is the one way of assessing the fetal heart sound and not using the color over there at such early stage. Am I right?
Yeah,
Anything?
and the spectral Doppler, because
Yeah.
when one gets into, the patient is going to ask, "Kya hum heartbeat sun sakte hain?" No.
Ah,
Always tell them at this stage, no. When you come
Yeah.
back at your 11 to 14 week scan, we'll definitely make you listen to the heartbeat.
correct, correct. That's great. And any sign of the ultrasound at this time that we have found out that it's nearly a pregnancy loss? What should be the signs we'll look for at this stage?
Absolutely. If you're looking at from your 4 to 10 weeks, and we have specific set criteria, what
Yeah.
you're looking at is, if you're looking at a crown rump length of more than 7 millimeters, you're
Yeah.
not seeing a heartbeat, you know it's trouble. You're
Correct.
looking at a mean sac diameter, and make sure that you take 3 measurements in 2 planes, measure inner to inner. And if you still do not see, you know you're looking at trouble. See, such a big embryo, you're not looking at, we know this is a pregnancy loss. But
Correct.
if it is, let's say, 4 millimeters or 5 millimeters, benefit of doubt to be given, and you're going to be calling the patient back again after a week. You're looking at a huge gestational sac. MSD definitely more than 25 millimeters. You're not seeing a yolk sac or an embryo. So
Correct.
we know we're looking at trouble over here.
Correct. So for the early pregnancies, all these are the few features which we can elicit to find it out that we are heading towards the trouble. Am I right?
Absolutely, absolutely.
Yeah.
And
So
you need to be cautious, because what I see is 3 millimeters, 4 millimeters, and okay, let's terminate because we're not seeing a heartbeat. They come back after a week and there's a heartbeat. So try and avoid such situations. It's not that only IVF pregnancies are precious. Each and every baby is precious for the parents. You need to be watching out. There is no harm in calling them back again after a week.
correct, correct. So we have to do it again once, or once we have diagnosed that it's a nearly a pregnancy loss and we are trouble, do we have to evaluate it as early as possible, or we have to say it and confirm it at the same time?
See, if we have these findings, more than 7 millimeters, more than 25 millimeters, then we sure off. Or 2 weeks ago, you've seen a gestational sac, we did not show yolk sac, still not showing it, you know it's trouble. You saw
Yeah.
a patient 11 days ago, and you saw that there was, I'll just put in that slide, that more than 11 days, you were seeing a yolk sac, but you still do not see a heartbeat, you know that's trouble. So these are the
Okay.
newer definitions that have come up. So you need to be watchful.
Okay.
Serial ultrasounds always important, not only for FGR, but for sonoembryology also, as and when required.
Okay. Okay. So gestational sac and what is the correlation? We should go for it. Am I right?
Absolutely.
Yeah. Okay. So what should be the possibilities when we think about and tell about that, how many percent of chances that this pregnancy is going to be, we are in a trouble or we are not in a trouble with seeing the gestational sac and a yolk? Are the possibilities should be?
Yes.
Yeah.
The same thing that I showed you, the 3 portions. If you're looking at less than 7 millimeters, there is no heartbeat, see them again. But that does not mean there is trouble. It can. But these are the things that are going to tell you. If you're looking at a mean sac diameter minus the crown rump length, if it's less than 5 millimeters, or if by eyeballing you see that the gestational sac is full of the embryo, you know you're looking at an oligoamniotic sac. The interval growth is poor. There's poor sac growth. There's a large yolk sac. It's a large or a floppy amniotic sac. We know we're looking at trouble. If you see over here, that's the gestational sac. And I hope my arrow is moving and everyone can see that. That's the embryo. So you feel as if this gestational sac is full of the embryo. We know that is a oligoamniotic sac. Does not mean it's trouble. It means be watching out for so that there is no trouble later. Rather than calling them back again at 11 to 14 weeks, it's much better that you call them a little earlier. That's the cardiac activity. You know, this is such a big gestational sac. This is definite bradycardia. If you
Yes.
see, these are the factors that you need to be. If you're looking at less than 6 weeks, 100 to 130 is fine. But if it's less than 80 beats per minute, we're sure we're looking at trouble. 7 weeks, less than 100 beats per minute, we're looking at trouble. Be watchful for. These are the signs which can tell us that we're looking at trouble. Large yolk sac.
Mhm.
It's a twin gestational sac. We're seeing a heartbeat, but this went on for a missed abortion. This went off correctly because the yolk sac was fine. You see a large yolk sac, don't jump the gun, there is problem. There could be a problem, evaluate that. If more than 6 weeks after the last menstrual period and you do not see, just be watchful. It could be a delayed conception. And in the amnion, if you do not see an embryo, that's what we call an empty amnion sign.
Fine.
Be
Yes.
watchful for.
So these are the few signs which we talk about. Same with an eccentric position and a location of gestational sac is also important. Am I right?
Absolutely. See,
Yeah,
if
yeah.
you're seeing for these things, this is normal, comfortable. This
Yeah.
might lead to trouble, call them back again. In
Yeah.
the uterus, you're looking at that there is an abnormally located gestational sac. It's more towards the side. Again, always does not mean trouble. These are the possibilities. You could be looking at angular, interstitial, you could be
Yeah.
looking at a cornular. So if
Mhm.
I find the gestational sac here, I know it should have been here, but as long as we're looking at in the endometrium with a thin layer of endometrium lateral to the gestational sac, a thick myometrium lateral to the gestational sac, I'm comfortable.
Correct.
If you
Correct.
see over here, and it's not that you always need a 3D, that's a transfer section. I know it's not bang in the center, it's on the side with a thick myometrium more than 5 millimeters. I purposely not put in too much of theory. If you see over here, it's in the portion, myometrial portion of the fallopian tube, and that's what you call an interstitial ectopic or an interstitial pregnancy. See over here, you'll be going on the side, nothing over here. And the moment you reach the side, you see a thin myometrium. The endometrium is not around the gestational sac. Few more examples. Angular. This is interstitial ectopic.
Yes.
And then the third one where you can see for is we looking at in the fundus of a bicornuate or a septate uterus. That's what you name a cornual pregnancy.
Yeah.
Why you need to know about all this is because the moment you see angular and you say we need to terminate, no, we need to be careful so that if it's growing laterally, then might be a termination is required. Usually it grows more medially.
Yes.
That's on the right side. Left side is full of the decidual reaction. In fact, yesterday only I got a photograph from a doctor from Bhubaneswar, and they were worried what exactly is this? Is it an interstitial one outside? That was a separate picture altogether. It was a septate uterus, and they later confirmed it by doing a transfer scan. They didn't have a 3D, but they did it by looking at a transfer section.
Correct. So we are also worried about nowadays about the cervical pregnancy, the scar pregnancy, and worried about the what is the abortion in a progress or not. These are the way that are there some dilemmas are there because scar pregnancy has become a little popular nowadays, probably because of very expert people like you are doing sonography and it's a man-made thing. I always call it because of the previous scar is because of more and more cesarean section we do. So do you like to throw some light on this cervical pregnancy, scar pregnancy, and what is the abortion in progress over there? Is there?
See, what happens is the moment we have a cervical pregnancy, the next question comes in all the CMEs is why cannot be that it's the gestational sac which has come down. So there
Yeah.
are a few features. If you see an empty uterus or hourglass uterus, balloon cervical canal, you're looking at a sac in the cervix, a closed internal os, and you're looking at flow around it. Otherwise, the biggest pathognomic sign is if you see a cardiac activity in a gestational sac below the internal os, it's a cervical pregnancy.
Yes.
But if you're looking at an abortion in process, same
Yeah.
thing, you'll see a sac, but there'll be no vascularity around. The sac could be irregular, the os could be open, and when you're doing a sliding sign, you're pushing it. The gestational sac could change shape and get pushed. When it's a cervical one, it will not get pushed. So if you see over here, that's a cervical pregnancy.
Yes.
Cervical pregnancy. And the same goes for a scar pregnancy.
Yes.
When you see an isthmocele in a non-gravid uterus, the same way with the least pressure over there or the least resistance, the gestational sac tends to go inside the scar niche. So you're going to look at plenty of vascularity. You're going to look at that there is a cardiac activity inside also if it hasn't formed a mass. You're going to see that the cervical canal is empty and it's anterior to it. If you see over here, that's the cervical canal. That's the gestational sac. And you're looking at a thin scar area, and that's the beaking over there.
Yes.
Plenty of vascularity seen. So basically the location is going to tell you in the cervical canal, think of two things, abortion in process or cervical. If it's anterior to it, patient has had a previous scar, you're going to be thinking of a scar pregnancy.
True, true. So the scar pregnancy at the right time, if it is diagnosed, then the treatment will be better other than this. But the history is also important when we talk about the abortion in progress, or there is only a cervical pregnancy, am I right? Some bleeding or some history will be there.
Absolutely, absolutely.
Yeah. And when the point comes in what will be the right time to diagnose the tubal ectopic, number one, and when to suspect and when to diagnose, because most of the time patient comes to us when there is a severe pain and initially not being done, the sonography not being done, then they go with the pain and everything, shock, and then do the sonography and everything. So, but if it's a tubal ectopic, not ruptured, what we suspect and how to diagnose it, that's important.
If you're looking at a beta HCG more than the discriminatory zone, patient is not bleeding, please make sure that there should not be any ectopic. The side which has the corpus luteum, you're going to be suspecting more over there. If you're looking at a gestational sac in the tubal area in the adnexa with a yolk sac, with a cardiac activity or no, you're absolutely sure. But it does not always happen. So what you're going to be seeing is you could be seeing a mass over there. So if you're looking at a yolk sac and a gestational sac, it's a bagel sign. If you're looking at a mass, that's what we call a blob sign. Or you could be looking at plenty of free fluid. So if you're seeing free fluid and you know it's echogenic, it's blood with the patient sinking and the patient's symptoms are such that she has severe pain, then you know you're looking at a ruptured ectopic. So if you're seeing, there are two ring of fires. The one of them is a corpus luteum, the other is a gestational sac. Corpus luteum, gestational sac. So you need to be watchful, and if you see over here, you started to see free fluid over there.
So it's very important to diagnose tubal ectopic and to differentiate with a corpus luteal cyst. Sometimes previously, when the diagnosis was never used to be the proper one, the patient being the surgeries for the corpus luteal cyst have also been seen into the surgical the laparoscopy. So it's very important to diagnose tubal ectopic. Do you think the molar pregnancies are that common now, or we are able to diagnose it as early as possible?
See, the complete molar pregnancies we're able to diagnose very, very early when we're looking at basically all this, that we're looking at this sort of a pattern. So this is not a difficulty. The problem comes in a partial mole. So that's where you need to be looking at that the placenta might be showing such features, and you're looking at a fetus which is going small, and there is oligoamnios as well. That's when you need to think about a cystic placenta. Always should be suspicious for these things.
Correct. But about the molar pregnancy, I think you are doing so many sonographies. When we were the students, it used to be diagnosed when they come to 20 weeks, 24 weeks and whatnot they have, because of the advancements into the sonography in the early stage and sonoembryology is one of the very good subject being over there. So molar pregnancies, I think we diagnose as early as possible, but we are not able to confirm the molar pregnancy diagnosis because we don't do the genetic things, and we are like that. The problem is, I think molar pregnancy is changed scenario with the early diagnosis, but still it's important, we should know about. And anything we like to tell about, or a clue you can give when which type of the twin it is, and what about the twin pregnancy when we talk about?
See, the moment you're looking at two gestational sacs, you're very, very clear. If you see the left upper, you're looking at a dichorionic diamniotic.
Correct.
You're looking at such a thin membrane, you're sure of that you're looking at monochorionic diamniotic.
Correct.
The best way to figure out is single gestational sac. If you're looking at two yolk sacs, it usually should be a monochorionic diamniotic, because two yolk sacs would mean that. So that's a nice chart that I always follow. But the best is at your 11 to 14 week scan, looking for the lambda sign, looking for the T sign that decides which type of a twin pregnancy is it. And always be patient, never be in a rush, and never feel if there is a problem, always refer that for a second opinion so that we don't make mistakes.
Correct. Correct. It's very important because it's early diagnosis, and with the advances of ART clinics and everything, twins pregnancy were there. Though they have a good ART laws over there not to have it, still it's an important point to diagnose it as early as possible. So the last way that I like to ask when you talk about the sonoembryology, that the most important question which comes is, and we are when and where we should use the color Doppler in the first trimester.
See, when you're doing a scan in early pregnancy, 4 to 10 weeks, you are not supposed to be switching on your color on the fetus. If you want to look in for corpus luteum flow, yes, for sure. You want to be doing your uterine arteries for any reason, for recurrent pregnancy losses, you might, but again, it does not have any value. So, and when you're going to come from your 11 to 14 week scan, the next step, you can do an ultrasound, looking at the ductus venosus, looking in for tricuspid regurgitation, but always and always follow the principle of ALARA, ALARA, that is as low as reasonably achievable. It's not that you're switching on your color box on the fetus and let it remain there and you're chatting here and there. Never. If you really want your machine also to be fit and fine, if you're not doing a scan, keep it always on a frozen mode. That's always better. So these are the small things that you can always do. 11 to 14, you might use it on the fetus. Before that, you do not need to. For looking at the heartbeat, there's so many times when the doctors tell me or the delegates tell me that, can we just switch on color just to see the heartbeat? Well, you'll have to lower down the velocities too much. You do not need to be doing it, because either you're seeing it or call back the patient later.
Correct. So the role of color Doppler, anything which you want to talk about this sonoembryology as a concluding remarks over here. So I'll be happy that we have already most covered the one we diagnose the early pregnancy, what should be the scan referred one, what is the twin cervical scar in a short way, because it's a very crisp knowledge sharing platform. You can talk on the subject for, I think, hours together and teach people, but in Learn Simply, it's our idea is like that. So anything in a concluding remarks, you'll want to say something about it.
The home message which I'm going to be giving is, never shy away for doing a transabdominal scan. Always start off. You could be missing out on something high up. So if you're seeing the patient for the first time, do a transabdominal scan and then jump onto a TVS. Don't straight away do a TVS, because you could be missing out. It's not that routinely you're going to be missing out, but why have those patients suffer those 10 to 15% if you can figure out and do a good job? Filling up the bladder does not take too long, and you always need to be patient. Never jump the gun in terms of that, oh no, this is the diagnosis, this is the diagnosis. Keep your antennas on, keep your possibilities on, and always be watchful for what you're telling the patient, what you're writing in the report. If you're suspecting something, please write it in the report. Finally, that's what's going to be the most useful piece of paper that's going to be there if things go wrong.
Correct. Thank you so much for the crisp and everything you have talked about. And once again, this Tuesday Study Time, which I always call as a platform, is a dedicated, we call it, for the sharing the insights and the take work messages. Crisp knowledge on the various subjects through the conversation, and the leaders and experts like you, we always love to
No,
have.
this is, I would always say that, and this is all the best for your coming endeavors, and you're
Thank you
doing
so
such a
much.
great job.
Thank
We're
you
all
so much.
enjoying this Tuesday tea time and the programs that we're attending of yours.
Thank you
Thank
so
you,
much.
sir.
And
Thank you very
thank you
much
so much for
joining.
being with us. And we, everyone over here today, it's our goal to provide practicing Jiva and to assess the valuable information and the knowledge. And that can grow them professionally and personally. It's my idea about the Learn Simply, crisp knowledge and experts into the field. We can expand the network also and share your perspective also. Thank you so much for being with me, and love you all. Thank you so much for joining. Thank you so much.
Thank you. Thank you, Dr.
Thank you.
Jyoti. Thank you so
Thank
much.
you,
Thank
sir.
you, Dr.
Thank you.
Excellent
Kawita.
presentation, sir.
Thank
Moving
you. Thank you
from
so much.
Thank you so much. And thank you everyone who has joined today. And I think everybody is there whenever, I think the Kuldeep Singh ji is almost a popular person, and so many students can join also because they have already heard you so many times probably. But this is a crisp conversation and it will be useful for some. Thank you so much, Sarji.